You're all very welcome. Just going to give one more minute just to make sure everyone's connecting and stable and ready to go. I can see some cameras coming on as well, which is great. Denise, hi Denise. I can see Frederick's here, Sue's here, Naila's here. Lots of people here. I can't go through everyone. It's amazing. You are all very welcome to today's session. We're delighted to have you with us here for the launch of the Nursing Now Challenge Global Solutions Initiative in collaboration with Edinburgh University's AMR Futures Lab, which you'll learn all about in today's session. My name is Dr. Carl Tizard-Kleister. I am the director and co-founder of Health Action Training, and I've been working alongside the fantastic Nursing Now Challenge for many years, delivering our training and other resources to the network. And it's been a joy and a privilege today, and I'm really excited to have been asked to moderate and host this session with a brand new partner for the Nursing Now Challenge. I think it's quite nice that an existing partner is working alongside and welcoming a new partner to the Nursing Now Challenge network. As you all know, hopefully you do, if you don't, this Nursing Now Challenge is a program of the Burdett Trust for Nursing, a global community of over 250,000 students and early career nurses and midwives. And their whole ethos and mission is to support their membership and provide leadership development opportunities and all other hosts of resources and support. And as I said, I'm really excited to be here. And today we're also joined by Professor Till Bachman, Chair of Molecular Diagnostics and Infection at the University of Edinburgh, part of the AMR Strategy Lead for Edinburgh Infectious Diseases, Chair of the Edinburgh AMR Forum, and founder of the AMR Futures Lab. We're also joined by Dr. Manish Paul, lead co-inventor and program director of enmetazobactam, a trained clinical microbiologist and antimicrobial stewardship champion. We are also joined, I hope, by Atika Shaheen, has joined or will join us soon, a registered nurse based in Pakistan, who's going to be sharing their perspective on antimicrobial resistance and the nursing role in that. And we also have with us Rohini Nilkatan, fourth-year nursing student midwife at the University of Leicester, who's also going to be sharing the nursing perspective, particularly the student nursing perspective on antimicrobial resistance. And last but certainly not least, working the controls under the name Nursing Now Challenge is the fantastic Hannah Finch, Director of External Relations for the Nursing Now Challenge and the do-it-all person for the Nursing Now Challenge. So a few housekeeping things, folks. Just note that the session is being recorded. We do encourage you to share this widely. The recording will be available, I believe, on YouTube and through the Nursing Now Challenge afterwards. So if you have to miss part of it, you can catch up, or if you want to share it with colleagues, you can do. If you have any questions throughout the session, please feel free to put them into the chat box. You can message it to myself or Hannah directly, or you can share it with the whole group. And we will keep that towards the end of the session, which we're going to dedicate towards a Q&A for the wonderful Professor Till and Dr. Manish. We are very happy for you to ask that question via the chat box. We can invite you also to unmute and ask that question verbally as well, whatever your preference would be. So that's everything I think I have to make note of. I'm sure Hannah will correct me if I'm wrong there, but let's get started with today's session. And I'm really, really delighted to hand over to Professor Till and Dr. Manish, as well as Hannah as well, to give us an introduction and overview on AMR, the Global Challenge. And I believe, Dr. Manish, you're going to be starting with that. Over to you.
Thank you, Carl. Till, you would share the slides?
Yes, I'm sharing. It should come.
Thank you. Thank you. Well, so you want to begin, Till, introducing this part?
Oh, no, it's
okay.
It's all yours.
So,
yes.
As we launch the Nursing Now Challenge Global Solutions, along with the AMR Futures Lab, which is for an AMR initiative, I'm reminded of the very famous old song. I don't want to sing it, but just to cite the wordings. There comes a time when we heed to a certain call, when the world must come together as one. That's a song that we are the world. So I think it's the time, the call is now, because antimicrobial resistance is not a distant thought or in the future we have to think about there is going to be. It is already. It is a time now when we must all come together as one world to address this challenge of antimicrobial resistance. Till next slide. This is my brief background. Where from India, the first time ever an invention has been approved by US FDA. That's an antimicrobial agent called as enmetazobactam. It's a beta-lactamase inhibitor. And that being the first one ever from India, it's a proud moment for all of us and for the country. And I'm very much privileged to be the lead co-inventor of that molecule. That's something I can boast about. But an invention is always a collective journey. And even this invention is contributing towards addressing the antimicrobial resistance, especially to ensure that we have the older antibiotics back in action and sustain them for a longer period of time. Next slide, Till. Thank you. Yes, when we look at the statistics of the world of antimicrobial resistance, it is quite alarming. This is not to get scared. When facts hit us, it's always good for us to have a balanced mind and look at the challenge and then see what can I do and what can each and every one of us do. Cite a four major points I would say is AMR is projected to cause 10 million deaths annually by 2050. That's quite scary. Now it's already 1 million a year, but I think that's going to increase if we do not have any more antibiotics with us. And the second is, of course, the economic burden. When we say economic burden, no infection functions alone. When there's more hospital days, there is so many wasted days of man hours which are lost, and also the loss of income, especially in the lower middle income countries where many of them live on daily wages. Those are the people who get much more affected, and also the cost of assistants who come with them. It impacts the healthcare system as well, and chaos everywhere. And the third is the public health emergency, and this undermines the pandemic preparedness because if there is an emergency, I don't think we have enough resources to handle an infection. SARS-CoV-2 has been a great teacher who alerted the whole world that how powerful these microscopic organisms, when they come together, can be. So we are filled with microbes, of course. We are, as per the literature, 2/3 microbes and 1/3 is human cells. But if we have to save our lives together as a human race for a longer period of time on this earth, I think we need to come together and not impact only the healthcare system, but rather impact our lives positively. And can we go to the next slide still? Thank you. Now, here, very specific to this topic of what we're discussing with the nursing. Now, I have put about several points here. One is the frontline detection, early action. Nurses are actually often the first line of to identify infection symptoms because nurses constantly are interacting with the patients and looking after the patients. So they can also identify the deterioration level and also any failures in treatment. And they are the ones who would help enable early cultures and escalate the matters to the concerned clinicians at the right time. And then, of course, adhere to infection prevention bundles. The second aspect is infection prevention control. And we have a lot of champions, and I'm sure I'm speaking to the audience who are already aware of all these things. But it is always good to reiterate these points that it's the nurses who lead hand hygiene compliance. And unlike in many lower middle income countries, I think in the Western world, the nursing have got an authority or permission to even to correct a clinician if they are not following certain procedures. Then coming to antibiotic stewardship at point of care. And here is where I think very important aspect comes of right drug, right dose, and right duration. And this can be done by only the nurses. And they are the ones who monitor the adverse events, therapeutic response, and also they facilitate de-escalation because most of the time it doesn't happen otherwise. And the next point is education and behavior change. Nurses are the best connect with the patients, caretakers, caregivers, families, and communities where they can communicate and counsel them on completing treatments, avoiding misuse. Clinicians can do that, but the more interaction happens with the non-patient communities through the nurses, and because they act as the trusted communicators bridging clinical teams and also the public. Then coming to the data and surveillance contribution, here accurate documentation is very important, because when we know the intensity of the challenge, then we know how to address it. So documenting vital signs, infection markers, and days, how many days the devices have been, and use of antimicrobial agents, all these things can be done by the nursing. Coming to the leadership in multidisciplinary stewardship teams, here nurses, when they interact with on rotation with multiple different wards, and when they go on rounds, they can participate in stewardship meetings and give audit feedback and form the loops for quality improvement initiatives. Then finally, it is the nurses who safeguard vulnerable populations. They are the ones who protect the neonates. The hand hygiene is such a critical thing in these cases, also in ICU patients, surgical cases, elderly patients. So ensuring aseptic procedures and safe device handling and prevention of cross transmission. So, but the bottom line still remains is right drug, right dose, right duration. Over to you, Tel.
Thank you so much, Manish. And yeah, it's always a pleasure to get your perspectives on it. So yeah, from my perspective, so I just also put in a quick introduction slide here, and it's really to highlight, first of all, I'm working on molecular diagnostics and infection here at Edinburgh University as a researcher in the medical school. However, I'm really keen in translation of research activities into translation of research activities and generating impact. Really, that's what I'm driven by, and this is also reflected in the various roles which I've listed here. And it's really important from a perspective of the opportunity to get in touch for all of you. If you see something also as a part of the course of this activity, of this initiative, I'm really enthusiastic about the opportunity to engage with you as a community and bring things into action. So just recently, this year, we started our activity at the Futures Institute, and you see here an image here of the Futures Institute, which is the previous old hospital in Edinburgh, in the city centre. And this has been established as a new institute, as a new initiative to really bridge across disciplines, bridge across sectors, and facilitate communication and collaboration from an interdisciplinary and transdisciplinary perspective. And it's an public, it's an open building. People can walk in and interact with science and really make things happen. And this is why we're there with the AMR activities and setting up the AMR Futures Lab. Now, what is the AMR challenge? And as Manish has just described, it's a big challenge. And from our perspective here, as it's written, it's a wicked problem. It's a problem which is spanning across many domains. It's not easy to say where it starts, where it ends, and it's really challenging to have adequate, sustainable solutions. And really looking at the efforts in curtail AMR through research and development, a lot of, in perspective, it looks a lot, but look at other areas. But there has been funding put into antimicrobial resistance research and development, new drugs, diagnostics, vaccines, prevention, etc. However, we still have the issue. So there are many challenges with translating research and development ideas and projects into implementation and then achieve impact. And this is why we are starting the AMR Futures Lab. And this is the objective. And we come to this in a bit more detail after a description on a project which I've been coordinating, or where I'm coordinating still, which is the driver behind the Futures Lab idea, or it sits behind the Futures Lab idea as well. But it fits very well to today's session. And it's an illustrative example. It's not to say I want to see something from your side also in the diagnostics area, but it's an example. So So starting point is what do you have? What do you do if you have Tetrangi? And this is a project which is running in India in the northeast, and we have been working there. And people in the community, as it's described here, you have recurring symptoms, you feel sick, it's a sensitive topic, you don't want to talk about it, and you can't leave your home, medicine is expensive, and the healthcare facilities are far. So that's the situation we have been working in, and this is where we come in with the DOSA project. The DOSA project is a One Health project, or started as a One Health project spanning the animal domain, the environment, and the human health. And we work in the northeast of India, and it's about urinary tract infections. And Tetrangi is a local term describing the symptoms of urinary tract infection. So us going in there, having the idea of bringing a diagnostics to primary healthcare centers was, let's say, ambitious, but it also not immediately led to results, because many of the patients didn't seek care but stayed in the community. And what we found were only a few patients coming to primary healthcare, and we needed to do something about it, and to find ways to access them. And this is summarized here. Is a descriptor of what is seen in these primary care facilities. And then we have pharmacies who also sell antibiotics over the counter. The patients receive antibiotics if the doctor decides to prescribe them in the primary healthcare center. But really, the point of contact for these people in the communities are the ASHAs, the accredited social health activists. They are the community healthcare workers, primary point of contact for the patients. And we thought that is, or it turned out that this was the best way to access this challenge of urinary tract infections. So we approached and collaborated and really co-create solutions with the ASHAs in Assam through co-design sessions, through interactions with them, through workshops in Edinburgh, through what we call real-life walkthroughs in Assam, so engaging with community members, so with patients who have experienced urinary tract infection, and of course with the local health authorities. But really at the core, at the center, was the interaction with the ASHAs, who provided input into how a diagnostic solution should look like. And as it's written in the center here, it's about testing in the community, so at people's house, at homes, provide meaningful information, should be easy to understand, dispose, low cost, and should be environmentally stable. And this is what we developed. We came up with this solution. So it's a healthcare package, and I don't want to take too much time, but very happy to speak about more if there are questions. So healthcare package about information, it's data gathering, but at the core is a diagnostic test, which can be done at home, which then gives access to further healthcare by fast tracking into the primary healthcare system. So that is a solution which is developed in collaboration with the ASHAs, and now this is where we are at the moment. We have done field performance trials. We had a lot of educational sessions, and we have completed that, and we are now entering into the next phase, again, in a very, very close collaboration with the ASHAs. So this is an example how we thought this is, we saw the interaction with people at the implementation stage who are at the forefront of the interaction with the patients really provide the crucial information on finding solutions. So at the Futures Lab, the mission and the vision really is about bringing people accordingly, bringing people together from the different perspectives of the AMR challenge, and it's along the whole pipeline. So people with lived experience, patients, others, farmers, innovators, implementers, especially about implementers from all sectors and disciplines to, as we say, to spark the unexpected, really to come up with new ideas. Futures Lab is in the Edinburgh Futures Institute, and it's really a space for transdisciplinary and transsectoral collaboration, as I described it. So it's people from within the university, from all different disciplines, from social sciences, from science and engineering, from the medical school, from human health, from animal health, but also with the general public, from people from the outside, so from with industry, with government representatives, with companies, and so on. And it's really an objective to engage globally, but especially with implementation partners, to come up with solutions which can be then taken all the way to implementation and for impact. And for that engagement with people at the front line who understand at the forefront of the problem with AMR, understand what's required and what is possible. And with that, I thank you for now for listening, and wish you good luck with the competition, but I'm for sure we will have more questions. And I hand back over to you, Hannah, probably, or Carl.
Well, I can jump in as Hannah's unmuting and getting ready. It'd be great to hand over to Hannah to go through some of the details about this partnership.
Thank you, Carl. Yeah, bear with me 1 sec while I just find my slides.
Just as you're doing that, I'll take the chance to remind everybody, if you have any questions for any of the speakers, please do use the chat box. You can send it direct to us or to the whole meeting, and we'll make sure that that's asked at the end in the Q&A, or you can wait until the Q&A and we'll invite you to unmute and ask your question. I'm sure there's lots of questions bubbling away for people.
Thank you, Carl, and thank you so much, everybody, for taking the time to be with us today. Enormous thanks to Till, Manish, Den, everybody at the AMR Futures Lab for collaborating with us on this really exciting challenge. We're absolutely thrilled to be bringing this to you all, to the Nursing Now Challenge community. My name is Hannah. Sorry, I forgot to introduce myself. I'm the Director of External Relations for the Nursing Now Challenge, and it really is a pleasure to be here with you all today. I'm not going to take up too much of your time. Just wanted to take this opportunity to talk you through a little bit about the challenge and what it entails, you know, what you can expect. So obviously today is our launch session, and over the coming weeks we'll be holding 3 more sessions. You can see here we have one on the 3rd of December, 16th of December, and then the 7th of January. And the idea for these sessions is really that you'll be hearing much more from Till and Manish and Den, all about the AMR challenge that we face today. And you'll also be hearing from nurses and midwives around the world about their experiences in implementing AMR related projects and their perspectives on, you know, what can be done to tackle this issue. So you can see this QR code here. If you follow that, it should take you to the Nursing Now Challenge website, where you'll be able to find all the links to register for the upcoming sessions, as well as much more information that can help you in this challenge. So what are we actually asking you to do? Well, as I say, the kind of purpose of these next few weeks of sessions is really to give you a deep dive into this subject area. And then we want to hear from you. We want to hear your ideas. And we would love for you to come up with a short concept note in which you describe an innovative idea for a nurse or midwife-led AMR project that you would like to implement in your workplace or your community. As I mentioned, that QR code that I just shared before, which I will bring back in a sec, will take you through to the Nursing Now Challenge website, where you can find guidelines to help you develop that concept note. It should be no more than 1,000 words, so this really isn't very lengthy, and there are very specific questions to help you in putting that together. The deadline for submissions is the 30th of January, and we ask that you please share that to the email address that you can see there at the bottom, which is challenge@nursingnow.global. And of course, it goes without saying that if you have any questions between now and then, please don't hesitate to reach out to us. We'd be very happy to answer them. So just a few tips on how you can make the most of this challenge and really get the most out of it. We have a private Facebook group for the Nursing Now Challenge Global Solutions Initiative. I think there's over 1,000 members now, and these are all nurses and midwives from around the world who are really keen in taking part in these challenges and coming up with innovative ideas. So really encourage you to join that Facebook group, connect with other nurses and midwives around the world who have a shared interest and experience. The other thing is, as Carl mentioned at the beginning, we record all of our sessions. We know that it's not always easy for you to join live, so please do check out our YouTube channel where you'll be able to find all the recordings. Be creative. We want to hear, all your ideas, and be free of limits. Just really keen to hear your perspectives. Allow your creativity to flourish. And the last one might seem really obvious, but please do write in full sentences and make sure you answer all the questions in the guidelines document, which again, you can find if you follow that QR code there. I'll also pop the link to that page on the Nursing Now Challenge website into the chat in just a second. And obviously that you'll have the opportunity to ask any questions that you may have at the end. So just lastly from me, we will review all the submissions and 5 finalists will be selected. They will then be invited to join us for an online interview. And following that interview, we'll choose 3 finalists who will be selected as the winners of this challenge. Now, for those of you who have taken part in a Global Solutions Initiative before, you will know that there is always a prize. So on that, I'm very delighted to hand back over to Manish, who will tell you all about the exciting prize for this challenge.
Jill, can I have this last slide, please? Thank you. Yes. So one of the major benefits of for the winners is mentoring. You would have continuous mentoring in this program, and that is invaluable, is what I would say, because we'll have experts who will come and handhold you and take you in your journey in this. And the second is an opportunity to visit a healthcare center in a developing country, to begin with India. So you could really experience in the real life situation how the nursing happens in these rural parts of the country and what are the benefits of it, and that gives you an insight into comparing that with what happens in your own place. So that's the biggest learning, I think. These are the 2 things which we have put it on the prize. Till, you want to comment?
No, I think you covered it really. So it is the path is the achievement, I would say. So it's the opportunity to develop your thoughts and do the mentoring and take part of the mentoring further. I think that's a real opportunity, and we will do, as I said, with the Futures Lab, we are really keen to take things to implementation, have impact on AMR. So you have us fully on your side with this, and make use of it as you are hopefully going all the way through to be a winner here. And I think the opportunity to visit a center, as Manish has described it, seeing it firsthand and making advantage or taking advantage out of these opportunities to see firsthand, to speak again, and take this home, and take things forward at your own place based on the experiences there would be huge. And Manish is a fantastic facilitator in this respect. So I'm really looking forward to where this will take us. Thank you.
Thank you.
Thank you so much, Till, Manish, Hannah, for all of that information there. I'm really excited to see how this network of folks take up this challenge, and I'm sure you're going to get some really exciting, creative, insightful contributions from this cohort. What I'd love to move us towards is to hear from one of your members, one of your cohort members, folks, on their perspective of the AMR challenge, speaking as a nurse, a 4th-year student nurse and midwife. Rohini, I would love to invite you forward to share your thoughts with us on this global challenge.
Of course. Thank you, Carl. Yes, I'm Rohini. I'm a 4th-year student midwife. So yeah, my kind of the way that I see antimicrobial resistance relating to midwifery is as midwives, kind of what Dr. Manish said about that infection prevention, that early recognition, and we are in a position to make sure that those policies are being kind of in place as well. But then, and I think as nurses, that's definitely the same. But then aside from that, I think as healthcare professionals, especially if you're dealing with parents, so if you're a neonatal nurse or child's nurse or midwife, they're very open to learning from you. So you're in a real position to educate parents and also telling them kind of when antibiotics are needed, when they're not needed, so they don't go kind of having half a course or borrowing them from friends. And also in midwifery as well, thinking about that health promotion and antenatal vaccinations and stuff, obviously not to prevent them from getting bacterial illnesses, but to prevent them from getting sick in the first place and potentially needing the antibiotics later down the line. I think it's really important that globally there's access to the right kind of antibiotics and the diagnostic tools. Like I think Dr. Manish mentioned or Dr. Till mentioned about the diagnostic tools. And because especially midwifery, when you're giving antibiotics to the mum, that's also impacting the baby. So there's two people there that are potentially going to be exposed to antimicrobial resistant bacteria. And the last thing, I think, as a midwife, I feel like I've got to mention this one, is encouraging and promoting breastfeeding, because actually when a woman breastfeeds, her baby gets antibodies not only from the woman's current infections, but also past infections. And that, again, prevents that baby from getting sick. So I think there's so much that we can do from a public health and health promotion perspective on this. But I know that doesn't solve everything, but it definitely slows down that antimicrobial resistance. But yeah, thank you.
Thank you so much, Rahini. That's a really valuable insight. And nurses and midwives, being some of the most trusted professionals out there globally, have such a strong role to play in health promotion, public health, and education, just like you were saying, and already making changes and differences. And I think stepping into the global challenge of AMR more proactively is a fantastic thing to be doing for any young nurse or midwife, or any nurse and midwife for that matter. I think we're now ready to open up to some Q&A, unless there's anything else, Hannah, that you wanted to add at this point. No, great. So we can open the floor for questions and answers for any of the speakers, or for anybody you like, I suppose. And luckily we have one in the chat box from Elaine to start us off. Elaine Hill asks, well, actually, allow me to give Elaine the chance to ask this themselves. Elaine, would you like to unmute and ask this question, or would you prefer I read out the text?
I don't mind, but I was trying to save you some time, but yes, I'll go ahead. So I'm just curious really about the amount of the problem with antimicrobial resistance, how much of it is to do with the inappropriate prescribing. Because I work a lot with colleagues in Sri Lanka, and one of the things that they mention is that the antibiotics are often prescribed inappropriately for viral infections, and part of the contributing thing to that is patients expecting them. And of course, we have had this situation in the UK in the past, but we've actually tightened up on it a lot now, so we're much stricter with the prescribing. But I'm just wondering how much of a contribution to the overall problem that is.
It's a really good question, Elaine. Should we maybe hear from Till and then Manish on that? Unless there's someone you'd rather direct it at, Elaine, should we start with Professor Till?
Yes, thank you, Elaine. It's really good question. And it is, of course, that's part of the problem. How big it is depends on where you look. But I think in general, I would say it really depends. How you go about this. The inappropriate use of antibiotics, of course, should not happen. But the question is where it's coming from. And from my perspective, I develop and do research on diagnostics. From my perspective, we should always first we look at prevention. Any infection which is not happening is the best scenario. Then if something is happening, we should know what we're doing. For that, appropriate diagnostics or using diagnostics would be really important. So knowing, is there an infection, deciding, do I need to give an antibiotic? And then if I make that decision, which antibiotic should be prescribed? And I think those three questions are really keen. We see that there are, for example, biomarker tests which indicate the severity of infection. The CRP test is demonstrating that. Yes, we have seen the value of using such a test to guide antibiotic prescription. The question, should an antibiotic be prescribed? Unfortunately, the test is not used all over the world in the same extent. So it depends really on your healthcare context, on the system, on the healthcare system, if it is reimbursed, if the guidelines are there to do that. So this is a test which would indicate, as I said, if you should give an antibiotic. And then how big is the problem with regards to antibiotic prescription? If we look into the human side of things, of course, we have a huge consumption of antibiotics in the veterinary sector, and we can discuss appropriateness there separately, but here we talk about human. And the majority of antibiotics are prescribed in primary care, and the majority of antibiotics prescribed there are in respiratory tract infections. And so having a diagnostics which is telling us which antibiotic, an antibiotic is it used, is it required, should I give it, and then if so, which one to use, would be ideal. However, in primary care, we do not have tests which give us susceptibility to antibiotics available. I've not seen any real tests which can be done really at point of care in primary care. And there is a lot of innovation required for this perspective. So I think the area of antibiotic prescription, which is not guided by a diagnostics, is huge. However, there are, and as I said, it depends. There are other ways to make those decisions based on local epidemiology. For example, we have a lot of guidelines in the UK, which are giving strict guidelines on what to use based on those epidemiological information and data. So it is a tricky one, but I think we should always rely on diagnostics when we prescribe antibiotics. Over to you, Manish.
Yep, thank you, Till. And Elaine, that the point you made is quite valid. I would look at it two ways, in addition to what Till has covered most of it. But from socioeconomic perspective, what most of the clinicians try to do is, if they know that the infection control practices are not as expected, to prevent secondary infection, they would go for it, which is wrong. Right? Instead of fixing the problem, they would choose that. And the other way is, many of the patients, they would do their own research on the internet and come back and say, okay, as per my indication, this is what I should be getting. If you don't give me that, then probably you need to go and read up yourself. So that is the attitude many people have got, because information is in everyone's fingertips, but they are not curated information, right? And a lot of fake and incorrect information also floats on the internet by self-proclaimed, health evangelists who are talking so many things about, stuff which they're not qualified to talk to. And those are the things we need to bring control on also, in addition to helping the community, advising them in prevention, not to misuse them, but also bring in some control systems wherein people don't spread wrong messages about antibiotic usage. Or some people say it's not a big problem at all. And I'm like, okay, that's not right, because 100 years ago, our life expectancy was so low, and it has increased with the dawn of antimicrobial agents. And we're afraid that it may go back to pre-antibiotic era if we do not save the existing ones. So it is more of the messaging and the narrative we give to touch those right chords in people's heart and minds, including clinicians, to encourage them to be part of the solution, and rather than saying, okay, I have to take care of my hospital only or my clinic only. That should move away from that.
Thank you, Manish. And I'd love to invite Rohini, if you have any thoughts on Elaine's question there along the misprescription of antibiotics.
Well, I was just thinking it kind of prompted a question from myself, maybe to either Dr. Manish or Dr. Till. If what you're saying, Dr. Manish, about kind of getting people on board with understanding the right information about antibiotics and antimicrobial resistance, do you think we need to go to governments or kind of the policymakers and kind of get them to change things or implement rules to make that change and to reduce the problem?
Rohini, that has been pretty much done in a way, because there are policies, there are regulations, and if you see, say for example, any of the lower middle income countries, when an antibiotic is sold, there is a red strip mentioned it is a scheduled drug. You cannot be dispensing it without prescription. But how do we control it? The mob has been trained over a period of time that they have to depend on antimicrobial agents. So I think what we have to do is now, since we have just spent about 100 years with these antimicrobial agents, and we are coming to the end of cycle of antimicrobial agents if we do not protect existing ones and bring new ones on board, I think that we need to start encouraging people to understand that it is their immune system that fights the infections. Antimicrobial agents support in the process. It's not that it is 100% antimicrobial agents and your host is just sleeping there. No, host is the one. So how do we strengthen the host? And when we know there's a season coming in of an infection in a particular area, educating public on what are the kind of measures we take to prevent that. Just like SARS-CoV-2 during that its pandemic, we all used masks, hand hygiene, etc. But we overdid it, of course, the hand hygiene, removing our own gut microbiota, but we did not have enough information at this point in time. So we took that extreme step to tell everyone to hand sanitize. So this data-driven information, when it reaches people, I think that would make a change in people's thought process as well.
Thank you so much. That was...
Professor Till, do you have a response to Rohini there?
No, I think from my perspective, obviously I keep talking about diagnostics because without diagnostics, medicine is blind. We have clinical judgment and we totally respect that, and it's really important, and diagnostics should never be seen alone, but you would never drive somewhere without looking at a map before. So you need some guidance, and this is on one side, and on the other side, I think it's and a lot is what Manish said about the general understanding and the COVID example. Before COVID, nobody really knew about lateral flow tests and PCR, and all of a sudden, not all of a sudden, it takes a pandemic. And before everybody always thought when you speak about lateral flow tests, it was the pregnancy test. And when you show this now to students, they don't really know that, but they know the COVID test. So everybody knows about this now. You can bring things into people's understanding and the general public, and if people know about technologies, if they know about the opportunity to find out more about the situation, then you can, Elaine said something about the patient demanding antibiotics. The patients could demand diagnostics. They could say, well, what happens? Please use that. And that it is possible. And we have been coining the term diagnostics literacy. And diagnostics literacy is about understanding what is out there, what it can do, how much does it cost? What is the impact? What is really the opportunity coming from diagnostics? So a mutual understanding all across the patients, the prescribers, the funders, the payers, and the healthcare professionals. So everybody needs more of diagnostics literacy. And I think that gives us guidance. And also what is really important there are two things. One is this is a possibility to turn things more from this challenge situation we're in now, where we say, oh my God, AMR is really a problem, into an opportunity. We can do something about it. There is what Manish has done, developing of new drugs, but also developing technologies. And this is a way to achieve things for people themselves, so they can build their careers, that they can build businesses, and people in their jobs, like the cohort we speak here now, they may be in a brought into a position where they can do their job better with the appropriate tools. And that is another aspect which I would flag here already as something which I'm very aware of is, you know, in my area where when we apply for funding, then what people always write, oh, we develop a point of care test which can be done at the doctor's office or on the ward or so. And then you go into these settings and people say, oh, don't give me another thing to do. Don't give me another box which I have to find a space for. Don't give me another task which I have to do on top of my actual day work already. So this is why I'm very keen to engage with the people that are in the call and beyond, is really to understand what it is actually what you could do. Yeah, not a new tool, but how does the new tool look like? Or is it a tool at all which you want? Maybe it's something else. And it's not just about diagnostics for sure, but I think diagnostics are important. So what is it what would make a difference? And what would you like to see? So yeah, long answer, but I think it is a complex, it's a wicked problem, AMR. We need to look at all different perspectives.
You're absolutely right. It's a wicked problem, Professor Till. I am open for other questions, folks, but I'm going to take the chance, as there's no questions in the chat box or anyone raising their hand with a question, to ask a question of my own. Kind of bringing us into the topic here, thinking about this new GSI Global Solutions Initiative with the Nursing Now Challenge, and this cohort hopefully are going to take that up and send in their thoughts, their concept notes, and take that process on. Speakers, what do you think is the biggest or clearest gap that folks in this network are particularly well positioned to address in this global challenge? Maybe we can start with Rohini.
I think my knowledge on this subject is definitely not as much as Dr. Till and Dr. Manish, but I think as a student midwife, I think that holistic public health approach is definitely something that I think we have a massive influence over, because the families in our care are so willing to listen to us. So it's about that education, it's about that optimization of health through supporting that skin to skin care and that breastfeeding, and just making sure that women and their families are in the healthiest position to not need antibiotics and not fall ill as much as possible in an ideal world.
Prevention's always good. Till.
I would politely disagree with Rohini. She said that she doesn't have the same level of knowledge. And this is exactly what we would like to overcome, because I think you have, because of your position, you are at the forefront of those activities, and that is, we are here, and it's a co-creation, a co-design. We all learn. I'm expecting, and I'm already doing this by the interaction in the preparation of this challenge and the meeting, and what you just said, Rohini, is something where I can learn something. So it's about this exchange, and from my perspective, that is exactly this is my gap. Yeah, so I see this as, and I'm at the university, I'm an academic researcher. I do where I think is the gap of knowledge, and we work with partners, of course, to identify those gaps. But I think we need to engage with people at the forefront, who engage with patients, who engage with people before they become patients, as you just described it. Yes. What can we do in terms of our behavior, nurturing our microbiome so they stay as they are? They prevent us, the immune system that prevents us from getting really ill. What is the constellation in which we should operate? And for that, we need to bring in all the voices and all the experiences. And again, this is why I think this initiative is so valuable.
Thanks, Till. Completely agree. Manish.
Thank you, Carl. And I agree with Till, because Rohini, you answered most all the things that was running in my mind, which means every one of us who are here in this meeting are the forefront. And as I mentioned in my slide, that actually the nurses know the first hand exactly what is happening, because there's continuous interaction with the patient and continuous interaction with the caregivers as well, right? The families. So I think the solutions generally, I would look for solutions to coming from the nursing faculty more than and from the clinician side. Clinicians are in a very different orbit. Laboratory people are in another orbit, but nursing people are very close to the source of whatever is happening. So you're very good. Thank you.
Thank you, Manish. So any other questions, folks? I'm still going to take the opportunity to ask my own questions if folks have none of their own. So I wonder, as you know, the Nursing Now Challenge is a global initiative, representation across the world. Maybe you can speak a little towards the kind of regional issues that might be facing, the unique regional issues that might be faced by folks relating to AMR? As in, is there a different issue happening in South America that's not happening in the same way in Asia or Southeast Asia? Are there regional kind of challenges that could be interesting opportunities, borrowing from you there, Till, to face with this challenge? Till, what do you think?
Oh, absolutely. I think there is very okay, so there is an overarching challenge, but I'm for sure there are regional differences, and I think it will be important to again to learn from the different. I think international global collaboration is so important for us to learn in both ways, and we did this as I described it in India, and if I go here in Scotland and I have someone living out in the Outer Hebrides and the islands far off the coast, for them it's quite challenging to access healthcare. And so again, you can learn in both ways from this. And by the way, in Scotland, we are tremendously lucky that we have specifically from a nursing perspective, the AMR within the government in Scotland is handled by the chief, or the head of that department is the chief nursing officer in Scotland. So nurses have a very, very strong voice in Scotland, especially also in the AMR domain. So I think there we are very lucky from this perspective. But coming back to your question, Carl, I think it's really important to see the differences which are in the different regions, learn from each other, and you know, we have these classifications: high income country, middle income country, and low income country. I would say these are resource settings, and even within countries you have different settings, and in these different settings we will have different differences, and those need to be understood and potentially addressed individually. But always there is mutual learning, and this is again why such an initiative is so valuable.
Thanks, Till. I'm actually going to take the chance to ask Manish a slightly different question, just so we can cover a few topics here. This is a bit more practically aligned to the challenge itself. Kind of a two-part one here, Manish. So will the participants who take part in this and send in their ideas, will they get feedback on this if they're not selected into the final process? And also, would you say they'd need prior experience in research or innovation before they apply? What's your thoughts on that?
Oh, I think that question I will not be able to answer that question because we haven't made such a hard criteria there. You know, whoever probably Hannah would be able to respond to that question on the selection, how we do it.
Hi, thank you, Manish. I think we can definitely provide feedback for our finalists. And, you know, if anybody has any specific questions, you know, throughout the whole process of this challenge, as I say, please feel free to reach out to the email there, challenge@nursingnow.global. In terms of would we be able to give everybody who takes part individual feedback, I'm not sure. Really, honestly, I think it depends on how many people take part. But certainly the finalists and, you know, individual questions that come up throughout the process, be happy to address.
Thanks, Hannah and Manish. I think I'm looking at the time here, and I'd love to hand over to Till to give us some closing thoughts. And Till's also asked if we can have a photo at the end of the session, folks. So perhaps we can have as many cameras on as possible, see some of your wonderful faces to mark the occasion. But Till, over to you.
Yes, and thank you, Carl. So the also on the previous question, so and Hannah's response is correct. So it depends on how many applications we get. However, I am really enthusiastic about this, and if there are not hundreds of applications, then I would absolutely be delighted to give feedback. But it really depends on the numbers, and the value of this exercise for you and for us is in that exchange. I repeatedly said that during this meeting, so I would be absolutely striving to do that and give feedback, but it depends a bit. The other part of the question, do you need to have prior experience in innovation, or need to be a researcher? From my perspective, that's a clear no. You don't need to do that. You don't need to be a researcher in a research institution to apply for this. However, yeah, so that is my view on it. And in contrary, I think people who may not have innovation or research experience may come up with ideas which are not, let's say, restricted by prior disappointments in the research environment where things haven't worked, or they haven't received funding, or some other people have done other things which obsoleted your own ideas initially, or you were not the fastest. So come up with an idea and present it. I think that would be a huge advantage. All right, so I think we need to come to a conclusion because of the time. So I really would like to thank you all for joining today. We had quite some turnout, which is fantastic. It's really fantastic. It's World Antibiotic Awareness Week. So we are the second day, so this is a good marker at the beginning to have such a launch of such an initiative with that objective. To bring in nurses and midwives into the discussion. It's really important. Please do join us for the webinars. I'm really looking forward on subsequent interactions and the presentations there. Likewise, for me, it's always a two-way street to learn. And then I'm absolutely looking forward to your submissions then at the end of January. So there is a bit of time towards that, but time flies, and so start early, ask questions early if you need to get more further input, and it's not too many words to write, but it's at least there is something. So, but as I said, I'm very much looking forward to all your contributions and the interactions and the run-up to the competition. Thank you so much for joining, and then and thank you, Hannah, and everyone for organizing it. And please, can we switch on cameras and do take the screenshot? And if you want to keep clapping, that would be also good. If you don't want to switch on your camera, it's also fine. But you know, if we have tens of cameras on, you won't be seen in very big detail. Hannah, some further words of encouragement or possibilities here?
Sorry, I think everyone's a bit shy.
Don't be shy, folks. Come on. Thank you, Adini. How about
and I understand if you...
Hello. And Keen, anybody? Be great to see some people.
Catherine, I'm looking for familiar faces. I can see Catherine. Anyone who's a Nursing Now Challenge member, please turn on your camera.
You know, this is to send out a...
Thank you. We have a few more. Thank you so much.
Send out a powerful message to the world.
And Elaine has a very good point. Yes, of course. Sometimes cameras are an issue with bandwidth being low, and we understand, folks. But it'd be great to just for 2, 3, maybe 4, maybe 5 seconds to see a few more faces. We'll be very quick.
Thank you so much. Let's see if you do one more. Okay. Thank you, everyone.
Amazing.
Super. Thank you all very much. Hannah, do you want to say some final words to say farewell?
Yeah, well, just a huge thank you to you all. Carl, thank you for doing such a wonderful job. Till, Manish, Rahini, thank you. It's been such a joyful session. We've had so many people, and I'm really apologize to anyone watching this later today. If you haven't been able to join, I think we may have hit our limit. But yeah, please do encourage your friends, colleagues to take part. This is going to be a really, really interesting global solutions initiative. So thank you all ever so much. Have a wonderful rest of your day, and we look forward to connecting with you on the next session.
Thank you.
Thanks,
Thank you,
everyone.
Carl,
All
Hannah,
right.
Till,
Bye.
Rohini, and
Thanks.
Dennis.
Thanks, Till. Thanks for
Bye.
hearing.
Thank you.
Take care,
Bye.
everyone.
Bye.